Let's talk about heart failure. Heart failure is broadly categorized into heart failure with reduced ejection fraction, formerly systolic failure with LVEF lower than 40%, heart failure with preserved ejection fraction having LVEF 40% or more. Risk factors for heart failure: ischemic heart disease, incident of prevalent myocardial infarction, hypertension, diabetes mellitus, myocarditis, valvular heart disease, tachycardia, structural heart disease related to congenital heart disease, sleep apnea, excessive alcohol use, obesity, drugs like NSAIDs, genetic of non-ischemic heart failure. DSM is also associated with Duchenne's, Becker's, and limb girdle muscular dystrophies. Coming to the etiology of heart failure, depressed ejection fraction plus coronary artery disease like MI and myocardial ischemia, chronic pressure overload like hypertension or obstructive valvular disease, chronic volume overload like regurgitant valvular disease, intracardiac left to right shunting, extracardiac shunting, chronic lung disease, risk or pulmonary and pulmonary vascular disorders. Non-ischemic dilated cardiomyopathies, familial genetic disorders, infiltrative disorders, toxic drug-induced damage, that is metabolic disorders or viral, Chagas disease, disorders of rate and rhythm or chronic bradyarrhythmias and chronic tachyarrhythmias. Preserved ejection fraction is greater than 40 to 50%. Pathologic hypertrophies, primary hypertrophic cardiomyopathy, secondary hypertension, aging and endomyocardial disorders. Restrictive cardiomyopathies, infiltrative disorders like amyloidosis, sarcoidosis, storage disorders like hemochromatosis and fibrosis. High output states as metabolic disorders like thyrotoxicosis, nutritional disorders like beriberi. Excessive blood flow requirements are systemic AV shunting and chronic anemia. Clinical manifestations of heart failure are fatigue, shortness of breath at rest during exercise, dyspnea, tachypnea, nocturnal cough, diminished exercise capacity, orthopnea, PND, nocturia, weight gain or weight loss, edema of extremity, scrotum or elsewhere, increasing abdominal girth or bleeding, abdominal pain, particularly if confined to right upper quadrant, loss of appetite, kinestokes respiration, and somnolence or diminished mental activity. Physical findings of heart failure: tachycardia, extra beats or irregular rhythm, narrow pulse pressure or 3D pulse, pulsus alterans, tachypnea, cool or mottled extremities, elevated jugular venous pressure, dullness and diminished breath sound at one or both lung bases, rales, rhonchi or wheezes, apical impulse displays leftward or inferiorly, sustained apical impulse, parasternal lift, third or fourth heart sound either palpable and or audible, tricuspid or mitral regurgitant murmur, hepatomegaly often accompanied by right upper quadrant discomfort, ascites, presacral edema, anasarca, pedal edema, and chronic venous stasis. So cardiac X-ray will show pulmonary edema, that is cephalization of the blood vessels, and curly B lines or butterfly pattern, pleural effusion, unilateral or bilateral. 2D echo is assessment of LV size and function, as well as presence or absence of valvular motion abnormalities. Presence of left atrial dilatation and LV hypertrophy, together with abnormality of LV diastolic filling, provided by a pulse wave and tissue Doppler is used for assessment of heart failure with a preserved ejection fraction. This point is important. It will also helpful in assessing RV size, pulmonary pressures, and detecting call pulmonary. So these are the curly V lines perpendicular to the pleura. This is cephalization of the blood vessels, dilated high limb, and CT ratio is increased, that is cardiomegaly. This is a pacemaker. So CT cardiothoracic ratio, how do you calculate? From the center you draw a line from here, from the center to the maximum point on the right side, you add it to the maximum point on the left side, and you take the maximum thoracic diameter mostly at the level of costophrenic angle. So you divide the addition of these two by the diameter of the thorax. If it is greater than half, or what you can say is greater than 0.5, then there is cardiomegaly. Circuiting levels of BNP, that is B type of natriuretic peptide, and N-terminal BOPRO-PNP are elevated and highly sensitive. Soluble ST2 and galectin 3 are the other markers for prognosis of heart failure. So heart failure with preserved ejection fraction management, there is hypertrophy, fibrosis, and infarction and ischemia. General therapy include reduce the congestive state caused by caution not to reduce preload excessively. Blood pressure is controlled up. Maintain arterial contraction and prevent tachycardia. Efforts to maintain sinus rhythm in atrial fibrillation may be beneficial. Treat and prevent myocardial ischemia. Mimic heart failure as angina equivalent. Detect and treat sleep apnea, common comorbidity causing systemic hypertension, pulmonary hypertension, and right heart dysfunction. Adaptive servoventilation ineffective. Risk markers are hypertension, aging, atherosclerosis, and diabetes. Specific therapy targets beyond general management is RAS, renin-angiotensin aldosterone directed therapy. ACE inhibitors and ARB ineffective except in prevention. Aldosterone antagonist may be beneficial. Digoxin is ineffective, may produce hospitalizations. Beta blockers and calcium channel blockers ineffective. Phosphodiesterase 5 inhibitors are ineffective. Novel therapies is angiotensin receptor, neprilysin inhibitors show early promise. Isosorbide mononitrate ineffective. There is conotropic insufficiency, target pacing unproven. In case of acute decompensated heart failure, the management includes volume control and degrees of vascular resistance while maintaining attention to end organ perfusion, that is coronary and renal. Parameters associated with worse in hospital outcomes is burn level greater than 43, SBP less than 115, serum creatinine level more than 2.75 milligram per deciliter, and elevated troponin level. In patients with suspected heart failure, ask for cardiogenic shock. If there is yes, then circulatory support, pharmacologic and mechanical. If there is respiratory failure, then ventilatory support, oxygen, non-invasive positive pressure ventilation, that is CPAP and BiPAP, followed by mechanical ventilation. If it is immediate pre-stabilization and transfer to ICCU and ICU. Immediate phase, this is the urgent phase after first medical contact. Immediate phase of the initial 60 to 120 minutes is initiation of acute etiology, that is coronary syndrome, hypertension emergency, arrhythmias, MI, and pulmonary embolism. Immediate initiation of specific treatment, follow detailed recommendations as per ESC guidelines, and diagnostic workup to confirm heart failure, clinical evaluation, and select optimal treatment. So if there is congestive heart failure and you give patient, start the patient of loop diuretics, there is negative sodium and water balance, there is decreased cardiac filling pressure and improved pulmonary congestion. When there is decreased cardiac filling pressure, there is decreased ventricular dilatation, which leads to decreased functional mitral insufficiency. There is improved myocardial function and decreased decreased ventricular dilatation, there is decreased ventricular wall stress and endomyocardial ischemia, which will ultimately improve the myocardial function. Causes of diuretic resistance in patients with heart condition. First is non-compliance with medical regimen and excessive dietary sodium intake, decreased renal perfusion and glomerular filtration rate due to excessive intravascular volume depletion and hypotension due to aggressive diuretic or vasodilator therapy. Decline in cardiac output due to worsening heart failure, arrhythmias and other primary cardiac causes. Selective reduction in glomerular perfusion pressure following initiation or dose increase of ACE inhibitor therapy. Given starting the patient NSAIDs, primary renal pathology like cholesterol emboli, renal artery stenosis, drug-induced interstitial nephritis and obstructive uropathy, reduced or impaired diuretic absorption due to gut-wall edema and reduced pancreatic blood flow. Mechanical methods of fluid removal may be needed to achieve adequate control of fluid, particularly who become resistant or refractory to diuretic therapy. Extracorporeal ultrafiltration removes salt and water isotonically. Cardiac resynchronization therapy. In heart failure, there will be non-synchronous contraction between the walls and chambers of the left ventricle, impairs systolic function and ventricular filling. Mechanic dysynchrony results in wall stress and worsens functional MR. ECG showing widened QRS interval in the presence of left bundle branch block pattern is indicative of dysynchrony. Ideal candidates are LVEF less than 35, patients in sinus rhythm. NYHA class 3 or class 4 heart failure, Ventricular distant grin, that is 2D echo, and QRS duration 120 to 150 millisecond, QRS duration more than 150 millisecond.